Cerebral edema is an excess accumulation of water in the intracellular or extracellular space of the brain. Classifications of the cerebral edema: vasogenic, causes cerebral ischemia, later stages, focal inflammation, hypertensive encephalopathy or trauma. Massive cerebral swelling can occur within 20 minutes following a trauma. Tumor mechanism: due to a breakdown of tight endothelial junction which make up the blood-brain barrier, physical disruption by arterial hypertension or trauma. Tumor facilitated release of vasoactive and endothelial destructive compound arachidonic acid, bradykinin, eicosanoid, excitatory neurotransmitters, free radical histamines, subtypes. Hydrostatic cerebral edema seen in acute malignant hypertension results from a direct transmission of pressure to cerebral capillary with the transduction of fluid into the extracellular fluid from the capillary. Cerebral edema from a brain cancer. The cancerous glial cells or glioma of the brain increase secretion of vascular endothelial growth factor, weakens junction of blood-brain barrier. High altitude cerebral edema due to effect of hypoxia on the mitochondria rich endothelial cells of blood-brain barrier. Cytotoxic, causes cardiac arrest, encephalopathy, hypothermia, severe hypothermia, intoxication, dinitrophenol, hexachlorophene, isoniazid, triethylene. Ischemia, early pseudotumor, cerebral race syndrome, stroke or hypoxia. Mechanism: blood-brain barrier is intact. Blood-brain barrier remains intact. Edema is due to derangement in the cellular metabolism, inadequate functioning of the sodium-potassium pump in the glial cell membrane, cellular retention of sodium and water, swollen astrocyte in grey matter and white matter. Postmortem appearances in cytotoxic cerebral edema. There is an increased fluid in the contrast to vasogenic cerebral edema, where there is increased intravascular cerebral blood volume and interstitial fluid. The former cytotoxic brain is enlarged, firm and has a relatively dry cut surface. In the later vasogenic, the brain is similarly enlarged but is softer, has a very watery cut surface. Next is osmotic. Osmotic: excessive water intake, hemodialysis, hyponatremia, rapid reduction of blood glucose in a hyperosmolar hyperglycemic state, formerly hyperosmolar non-ketotic acidosis, syndrome of inappropriate antidiuretic hormone, SIADH. Mechanism: normal brain osmolality is less than that of a serum osmolality. Brain osmolality becomes more than that of serum osmolality. In above cases, creates a reverse pressure gradient edema. Next is interstitial edema. Interstitial edema causes obstructive hydrocephalus. Mechanism: rupture of a CSF brain barrier. Transepidermal flow of CSF penetrate the brain and spread to the extracellular space and in the white matter. Differentiated from a vasogenic edema in that interstitial edema, CSF continuous almost no protein extent. Cerebral edema may be focal adjacent to the area of injury. Diffuse unilateral involves one hemisphere only, occur mostly in relation to ipsilateral acute subdural hemorrhage. Bilateral involves both hemispheres. Postmortem appearances: dura, stretched and tensed brain, bulging, weight increased, cerebral surfaces smooth, gyri pale, flattened with a thinning of grey matter, sulci obliterated, cut surface pale, signs of herniation. Thank you.